Hello and welcome everyone. My name is Jonathan Banks, and I am a third-year DMD PhD student at the UIC College of Dentistry. Thank you for joining us for this groundbreaking video series, which will showcase some of our exceptional researchers and their pioneering research topics. As a student researcher, I've witnessed firsthand the research excellence at our college, which you will experience today. Now, it is my pleasure to introduce Dr. Sath Allareddy, professor in orthodontics, who will be discussing artificial intelligence and big data analytics in orthodontics. This subject is at the forefront of many fields, not only in research, but in the broader technological landscape. Dr. Allareddy?
Thank you, Jonathan, and thank you all for making time to attend this presentation. Over the next few minutes, I'm going to unpack what my research is about, how I got into clinical outcomes evaluations research, and the future directions in my lab. I'm a cleft craniofacial orthodontist by training, and I specialize in providing orthodontic care for those with craniofacial differences and complex malocclusions. As a clinician, I'm very interested in learning more about what processes of care will enable me to deliver the highest quality of care to my patients. My lab uses big data analytics and artificial intelligence technologies to evaluate clinical outcomes in the continuum of cleft and craniofacial care. So what got me into clinical outcomes research? I'm going to take you back to 2010 when I was a third-year orthodontic resident. So 3 months to graduation, I developed malaria during an international trip. What I had was black water fever. This is a complication of malaria, which is associated with a severe hemolytic crisis. Typically, the patients have a rapid and massive destruction of the red blood cells, hemoglobinuria, and multi-organ failure. And I had all three of them. I was hospitalized. I was in critical care for 4 weeks. I was on life support for 4 weeks. And following that, I was in a step-down unit for a couple of weeks. And after that, I had 6 months of post-discharge rehabilitation. They gave me a 1% chance of survival and a 99% chance that I would have end organ damage and lifelong dialysis. I survived, and this was my first experience to a US healthcare system in a hospital setting. For me to survive, every single activity in the continuum of care had to work well. And this starts with the 911 call that I made, then to triaging in the emergency department, then the care that was given to me in the critical care unit and the step-down unit, and the post-discharge rehabilitation that I had. The list was endless. And if you look at what happens in a critical care unit, every single day, there are over 1,000 activities that have to work in a very precise, seamless, and timely manner for a patient to survive. And I had access to the best healthcare, and I survived. And I got interested in evaluating these outcomes, and that's how I took up this line of inquiry. So coming back to the present, this is an exciting time to be a healthcare provider. The orthodontic ecosystem is rapidly evolving with availability of large amounts of data from multiple sources. And there is also infusion of newer technologies such as artificial intelligence and an increasing emphasis on patient-centered outcomes. So this is a typical pipeline for an artificial intelligence model that we use in orthodontics to evaluate clinical care. Traditionally, in the field of orthodontics, malocclusions have been classified based on a single criteria, the relationship of the upper first molar to the lower first molar. And all malocclusions are classified as class 1, class 2, or class 3 malocclusions based on this single criteria, and we render treatment based on this classification. In our lab, we use big data analytics and artificial intelligence technologies to actually challenge this long-standing dogma of classifying a disease based on a single criteria. Advances in genomic sequencing, availability of multi-omics data, and artificial intelligence tools have enabled us to actually divide monolithic disease categories into stratified and more personalized disease concepts so that we can render etiology-specific therapies. And that's what we do in our lab. We are also very cognizant of the ethical issues stemming from the use of big data and artificial intelligence. In the current landscape, all the artificial intelligence models are developed from clinical data sets that are not diverse. Traditionally, disenfranchised population and racial minorities are underrepresented in these clinical data sets. In our lab, we use clinical data sets which are extremely diverse, and we develop race-specific models. So this enables us to mitigate racial biases and to minimize the healthcare disparities. This is an exciting time for the orthodontics because we have very matured artificial intelligence models which we can deploy in clinical care. And this is going to be the next giant leap for realizing truly precision or personalized orthodontics. As a patient, I had the best clinical care provided to me, and I survived my illness without any end organ damage. I was charged $2 million by the hospital, but of course I paid only $20 for two $10 visits for 2 outpatients visit, and that was thanks to my insurance plan that I had as a resident. I think every single patient is entitled to the highest quality of care, regardless of their ability to pay. And I hope my research is helpful in this endeavor. Thank you.